Thanks everybody for joining us this afternoon. This is Michelle Similis. I'm Vice Chair of the Global Health Council Board, and I'm also Executive Director of Bread for the World. I'm so pleased to be here to be part of this conversation. We have a really interesting panel that are going to share some insights both from the ground and from an analyst point of view about what's happening with the COVID pandemic. So I'm just going to, without further ado, turn it over to Jen Cates, who is here from the Kaiser Family Foundation. Jen, do you want to start us off?
Sure, and thanks so much, Michelle. And I just want to thank Michelle and Lois and GHC for, reaching out to us and asking if we would, do this together. And we're excited to be able to do this. It's a difficult time for everyone, and we're just hoping that, this conversation, we know it's a continuation for everyone on in the community, but that this could just keep moving along and we could provide some updates on some of our analytic work. So without delay, just going to the first slide. So just there are a lot of great trackers out there. We have one on our website. This is a screenshot from the 22nd. So of course it was out of date immediately. And sadly, as of today, there's more than 3 million cases and more than 200,000 deaths that have been confirmed. So this is on our website, and we encourage everyone who needs to access information. You can download it and manipulate it there. So just wanted to highlight that. Next slide. Also, we've been tracking, I think a lot of us have as well, tracking the different emergency spending packages that Congress has passed and the president has signed. There are 4 that have been passed so far. I've listed them here and the date that they were enacted. Actually were passed, and some of them have local components, but we've done analysis of each of them, and those are on our website. So if anybody is looking to get more detail as to what funding is being provided, for where, for how long, we have full analyses of those on our site, and we'll soon have the Paycheck Protection Act up as well. That's the one that just passed. Sorry, there's a little echo there. And we understand that Congress is continuing to look at further relief that can be provided. So we will also continue to analyze that. Next slide. And just to give you some specifics, I won't read all the detail here. 2 of the 4 spending bills did identify specific money through agencies to address COVID efforts in low and middle income countries. The first one, the Coronavirus Supplemental Appropriations Act, and then the CARES Act, the second. And we just identified here, which you could also find on our site, what funding was provided to which agencies. So for the first one, it was CDC and USAID. And then the second one, it was CDC, USAID, and state. This is funding that the agencies are using going forward. And I understand potentially we have USAID on backfilling maybe a little bit of some of the early quick response before these passed. But funding, and I'll highlight it very briefly, has already been provided to many countries through this support. Next slide. And so this is as of April 22nd, the US government has provided about 775 million to countries, to over 100 countries. And country-specific funding that's been allocated to countries is close 463 million, and that's 102 countries. And this is where I'll get to our analysis in a minute, but many of the countries, not all, but many of them do overlap with where the US is providing global health assistance. And that was the purpose of our analysis. Next slide. We wanted to understand potentially where there might be opportunities for leverage or potential challenges that could arise where there were programs that the US was already supporting. So this is an analysis that we did initially. We've just updated it, and we'll try to, going forward, we'll keep it updated. It's on our website, but just to give some highlights in a couple of slides, we identified 108 countries that are either receiving US global health assistance, so that's 64 directly, or receiving COVID-19 assistance, and that's 102. Most of those 108 countries have reported COVID cases. This is a few days ago. So we have a lot more detail on our report about this, but we wanted to, as I mentioned, identify where there might be some overlap or not overlap. Next slide. And this gives you a sense by region. These are not to be added together, but this is, for example, in Africa, in the African region, there are 34 countries that receive U.S. global health assistance, and there's 41 countries that receive COVID-19, in the region that receive COVID-19 assistance. And our report will let you see which those are, where there's overlap, and not just where there's overlap, but what the program is. Is it PEPFAR? Is it the maternal and child health program? Is it family planning, reproductive health? Again, so it provides maybe some data on where leveraging can happen, but also where particular attention might need to be paid. Next slide. We also, when we just did the update, we looked at WHO's ratings of countries on preparedness capacity level, which is something that WHO has updated a couple times as well, but it basically rates almost all countries on their, at least according to some basic metrics, how prepared they are to respond. And 5 is the highest level of responsibility. So this is just on, I would say this is mostly looking at data available for countries, but not necessarily how they performed, but what they could be expected to do. But as you see here, most countries in which the US provides assistance are 2 or 3, which are not the lowest tier, but the tier in the middle or further down that we would expect would need more help and more capacity building. Next slide. And then finally, from the report itself, this is the crosswalk where you can actually go see each country, what region they're in, the cases that were reported as of a certain date. And then I think what hopefully will be helpful is where you can actually see what U.S. global health programs are operating in those countries, meaning that they receive some funding, and how much COVID-19 assistance they had. We also wanted to flag that there are some countries that may not get any global health assistance, but are getting some other kind of foreign assistance. So we did indicate those. Next slide. Okay. One last thing that we've also been analyzing is not just from the US government lens, but broadly speaking, what are donors doing to support low and middle income countries in their COVID-19 response? And this report also was just updated, and it's our attempt to catalog funding from donors, governments, multilateral organizations, and the private sector that's either been pledged or distributed for such support. And by our latest estimate, it's about 19 billion in at least pledged or in some cases distributed support. And we detail that amount by donor in a pretty big table. And before, I think that might be my last slide, but before I finish, I just want to acknowledge that this work that you're seeing is really the product of my amazing team, Kelly Moss and Stephanie Ohm, who are joining me today. And they really worked very hard to pull all of this together. And we're also excited to hear your questions and also your other analytic needs, because we're really trying to, that's where we could hopefully be helpful as you all do the work, the hard work, primarily, working as implementers and in the field. I think that might be my last slide, in which case I'm happy to take questions now. We have a lot of amazing speakers, so why don't, unless we see chat questions coming in and we can start answering those, we can probably just move forward. Okay.
Hi, this is Michelle. I think what we're going to do, because we don't have any questions in the chat space quite yet, is we'll move to the next speaker. But I want to call everyone's attention to this slide, which just shares with you, if you have a question, just type it into that chat box. Please indicate your full name, your organization, and then we'll be sorting through the questions, and we'll do a Q&A at the end to get our whole panelists to be able to answer. So our next speaker, I just want to welcome Parvi, who has been with me on the Global Health Council board, and she's the president of Medtronic Foundation, and she's going to be talking about the impact and adjustments that they have had to make on the ground.
Thanks, Michelle. Hello, everyone. And again, just hoping everyone is keeping safe and healthy. I think we're all adjusting into this situation every day. And the thing that's the greatest equalizer right now is that, like our partners, we're managing through how we do our work in different ways, having to work from home while still trying to deliver what we do. And that only brings the pressure of what our partners are feeling around the world in the same lens. And I lead Medtronic Foundation, and what I'm just going to walk through are some implications that we're seeing, and really am representing the hard work of our entire team. And before I go into the specifics of it, I think it's important to also recognize that the private philanthropic sector is also very diverse. And so what I'm talking about is what a corporate foundation does, which is very different from what you might see from a Ford Foundation or Rockefeller or Gates at many levels. One, in terms of the volume of resources that can be offered, but also the mix of things that we do. And so corporate philanthropies really bring the power of financial investments and resources together with volunteerism and the variety of contributions that employees can bring as well. And each of us, no matter what sector you work in, have the opportunity to give back through our own charitable giving, as well as the time that we can give. And if you happen to work for an employer that matches that in any way, that redoubles our effort in what we can do. And so the mix of things that Medtronic Foundation is bringing in response to COVID involves all of those levers. What that has meant for us is that we luckily are also a healthcare company, and many people on the foundation team, myself included, as well as Jess Daly, who is a leader in global health as well, have been in pandemic responses almost throughout our entire career at various levels of evolution of a pandemic. And so we had ear to the ground very early on, like many of you on this call, in sorting through what would be the best possible response for a corporate philanthropy. And what that meant was doing all the classic things that we all were doing, which was making sure we were in great support of CDC and WHO, and making sure we were timing what we could do based on when the levels of severity were being activated. We've supported the big solidarity funds that are in the mix, as well as a variety of other resources, knowing that we needed to be very careful with our resources to make sure that they would be leveraged far and wide in the first phase of the response. We activated a classic disaster relief response when things were emerging in China, but made sure it was positioned with organizations that tend to be very good in disaster relief responses, like Direct Relief, International Medical Corps, Red Cross. There's a family of well-known organizations that get to help fast. And we certainly positioned well there, but we knew that we would need to overlay that with well-seasoned global health organizations when the time was right. In addition to that, we also knew that this isn't just a health crisis, it's also an economic crisis that's in play. And in a lot of key locations around the world where Medtronic is acting or has a very large footprint with our own employees, we've made sure that we were lifting up local COVID-19 relief responses. Much like the WHO Solidarity Fund, or the CDC Foundation response, these local relief funds are set up so that we're able to shore up the community front line that, in addition to the health front line, is supporting those very small and mid-sized nonprofits that need bracing in this moment because of the vulnerable populations they're there to serve, also fragile funds that are in an unrestricted view. Where it's unlocked from programmatic funds, but unrestricted resources where they can respond quickly. And so we wanted to make sure that was shored up. Finally, we know the vulnerable populations represent a very diverse and often forgotten mix of beneficiary populations in every country of the world. And so we've been keeping an eye on what to do there, and have been doing what we can with larger economic opportunities like food relief and making sure the elderly are cared for. What we've seen on the ground, though, as we're looking in emerging markets and inside of the LMIC world, is that no matter the organization, no matter the sector, a lot of the grassroots organizations on the ground are struggling to stay afloat. And while it feels like there's a lot of resources in play, whether it's private philanthropy, corporate philanthropy, or the public sector, what Jen just outlined, we know that those that are actually providing services on the ground immediately are struggling to get resources. And so we've been relaxing any kind of conditions that we can on nonprofits on the ground to make sure that they can use the resources we've deployed, even if programmatic, so that they can take care of themselves first and their staff, but also ensure that resources are being deployed where they need to be. What I can say, though, is as we move ahead and think about what is it going to take to knit together the strongest response here, is that, you know, private philanthropy can only go so far. It needs to be woven in tightly with what a public sector response is, whether that be a global sector response or a local one. And the sooner we're able to steer into that effectively, the better for all. We're going to continue to stay the course in looking at various ways of supporting, you know, a larger COVID response, while also recognizing that as we move through, pick your framework, whether it's a relief to development continuum or phases of a pandemic and the way you craft a response, these two are going to come together. These two frameworks will come together into what is the new normal for everyone. And we are starting to play out what would this a response look like on the other side of the immediacy of what we're all doing. But the majority of our response is very much rooted in what's happening at community level. The final piece I'll say is beyond the financial, as I mentioned earlier, the unique offering of a corporate philanthropy is in the power of the employees that we have, and especially if you happen to be a healthcare company, we have highly skilled employees that are very well versed in sorting through some of the specifics of what's needed, including many of whom are medical professionals themselves. So we are activating virtual volunteerism, where we're pairing some of the highly skilled employees that we have with some of the needs that nonprofits or others may have in being able to craft a response. Luckily, in June happens to be the time that we kick off employee volunteerism all over the world for Medtronic. And that's right around the corner in response. And so we are going to lift up very a virtual platform that allows us to connect and pair basically technical assistance, but all through what employees and companies can provide, and specifically our company. The last bit I'll say is, you know, I'd be remiss if I didn't talk about what Medtronic as a company has been doing. And I have to say, as someone who's worked in the private sector for a bit of time in my career, it's been heartening to see how so many different sectors of industry have been creative and have jumped in to respond inside and outside of healthcare. For us, we certainly have doubled our effort in providing vendor and manufacturing ventilators, as well as partnering with a variety of other companies to be able to help accelerate that need. And moving fast in what we can do with lower, you know, the lower end ventilator that isn't necessarily requiring as much technological assistance, and including technology and doing a variety of things to make sure that we can manage chronic illnesses as we go forward. We know that the NCD response that we've traditionally had a large voice in is impacted by what's happening with COVID, as everyone is seeing the impact of the virus on stroke, cardiac arrest, and a variety of other things. And so we're lifting up that front line through the EMS, and also ready for that dialogue on NCDs, where we start to once again bring the artificial barriers between non-communicable and communicable diseases down, and recognizing we need to do our best to respond to vulnerable populations around the world. So I'll leave it there, and if there's any questions, happy to respond. And again, thank you for everybody's hard work in this issue. We're going to discover something new and hopefully see a lot of really great opportunities that tend to show up during times of crisis like these.
Thank you, Parvi, for that update. It's always good to hear from you and from Medtronic about how you're experiencing the this crisis. I just want to introduce the next speaker. Our next speaker is Dr. Gloria Ekpo from World Vision, who's also going to talk about, from a INGO perspective, how they're doing.
Thank you very much for giving us the opportunity in World Vision to share our experience on the impact of COVID-19 on our global programs and the adjustments we have and continue to make to ensure that we support vulnerable communities in more than 70 countries. The scale and severity of COVID-19 globally is in almost all countries and is impacting many communities, including those we work in. I will focus my presentation on two main areas. One, the impacts of the COVID-19 on our programs, and two, the adjustments and our response so far to ensure vulnerable families are cared for around the world. On the impact, our global health and social programs have been affected. Countries are in lockdown, closures of schools and non-essential services, travel restrictions, social distancing, other local guidance have affected our traditional way of doing work. It is safe to say that this pandemic continues to affect programming, at least to some extent in coming months. In some countries, programs have moved forward, though slower, and in others, they have been paused as staff are made to work from home. Some of the specific areas are affected in our training of frontline workers, like community health workers, religious leaders, teachers, volunteers. These have been postponed because of social distancing and limitation in crowd gathering. Program activities also like savings and loan groups have been postponed. Malaria bed net distribution campaigns delayed. HIV testing services have also been cancelled as project efforts have been diverted to support national governments to respond to the COVID screening in their countries. Our school-based program like Coaching Boys into Men in 7 countries have slowed considerably because of school lockdown and closures. Procurement of malaria supplies, water sanitation infrastructure have also slowed down on account of this. And also donor mandated closures have impacted the way we do work in several countries. And for project management, we are made to do this virtually as staff as our staff work from home. And how has World Vision responded to this pandemic? At its onset, World Vision declared COVID-19 global health emergency response focused on limiting the spread of COVID and reducing the impact on vulnerable families and children. In this response, she is focusing on initial 70 countries with preparedness, response and recovery plans to reach 72 million people, of which 35 million are children, and mobilize with budget reprogramming 350 million, focusing on where people need it most. These countries have been chosen because of the COVID high rates of transmission, their low health capacity, as well as extreme vulnerable populations, especially those displaced and in refugee settings with unhygienic settlements with short and long-term impact on children. The secondary effects of this crisis on children could be devastating as families and community structures, education, health services, and livelihood are shut down, forcing millions into poverty and vulnerability. Our response has actually targeted 4 main areas: scale up prevention, support health system and workers, support the children and families, and advocate and collaborate with partners to protect children. As of April 24th, I'm happy to let us know that World Vision has reached over 6.7 million people with COVID-19 preventive messages, supported 160,000 community members with essential materials, established over 6,500 community hand washing stations and trained faith leaders. It has supported health system by training over 750 community health workers, provided personal protective equipment, distributed over 500,000 face masks, and assisted more than 500 health facilities in their response. She has also reached 178,000 children with targeted age-specific health education, provided family support packages to over 607,000 families, and distributed 1.3 million in cash and voucher assistance to families. While this is an incredibly challenging time, I believe that World Vision is well equipped to respond and be the hand and feet to those most vulnerable globally. Equipped with massive size, scale, expertise, staffing, local relationship, and strategically located supply centers, we are in strong position to continue to respond quickly and efficiently in support of this crisis. So in conclusion, I want to thank you again for the opportunity to share experience in our support for this global effort to prevent, contain, and mitigate the impact of COVID-19 on vulnerable families around the world. Thank you.
Thank you so much. That was really enlightening and interesting to think of, to hear how things are being impacted on the ground. We're going to hear from one other implementing partner, from Elizabeth Glazer, Pediatric AIDS Foundation, Chip Lyons from there, and then we'll turn to questions. And just a reminder, please put your questions in the chat with your name and where you're from, and we will then start asking them following Chip's presentation. Chip?
Michelle, thanks. I just have half a dozen points to make. It's not a formal presentation, but thank you also, Lois and Jen, for organizing the call and the request to join. EGPAF, I don't know exactly who's on the call, but we're across 16 countries, about 3,000 staff. We're supporting about 5,000 sites. What I'd want to focus on, health sites, that is. We're in a period of intense adaptation of HIV and TB services with often inadequate tools and resources to do the kinds of things you might be imagining or you would expect. There's a kind of quadrangulation that has to go on. There's the client need and client behavior on the one hand, staff and health worker safety. Secondly, there's a set of Ministry of Health policies and directives that are evolving. And then there are donor parameters that obviously have to be taken into consideration. And so we have all those sort of four factors have to be thought through and acted on with the central question, which is and the central tension, which is access to services versus safety. And so we've done what I think others have done, which is identify essential staff, essential services, but frankly, quite uneven distribution of personal protective equipment, which is an essential precondition, obviously, for keeping people safe. We anticipated a number of issues, and they've borne themselves out. There are challenges around stock of drugs and ARVs, supply chain challenges. One of the, I think, obvious steps to take, which we're taking wherever we can, is multi-month dispensing of ARVs. Makes perfect sense. It's not possible to do that everywhere for a variety of reasons. We also anticipated that there would likely be a drop-off in client consultations, fewer people going to sites. There's kind of a mixed message there. We need people to come to the sites for their essential medications, but part of the messaging is social distancing. And so it's another area of adaptation. There are some things that weren't as obvious to us at the beginning that have become more clear. The transport logistics challenges are very substantial, including where there's a lockdown or there's a curfew or an inability to have vehicles move with more than 2 people in them. And that's not a criticism of the directives. It's simply to say it throws a spanner in the works of needing to move supplies, move drugs, move people around for continuity of services. Getting reports from different partners of emerging food insecurity among those that are coming to sites. We anticipate that's going to get worse before it gets better. There's also a frequent mention of COVID stigma. That plays out in different ways, keeps people away from sites and so on. If you add to the stigma we see all the time related to HIV, it's a very difficult combination. Just 3 quick short points. There's a whole lot of public health system knowledge out there in the field. Practitioners, experts, clinicians, and so on at health sites who know about testing, who know about services from the lab to the clinic to the patient. That's where more resources need to be moved to those health activities that are going to help address COVID, but also to continue services to as much as possible for obviously vulnerable populations. So it's great to see the resources moving through bilateral and multilateral channels, but we also, it needs to move, and it needs to go into health actions as well that are reaching people at sites. Let me just close on a really positive note, at least it is to me. I see these and hear these examples all the time. The role of individuals, we refer to them in the aggregate as frontline health workers. There are some remarkable people doing remarkable things as we speak. Clinicians, senior clinician of sites who are having to work, figure all this out, being very creative in different ways, people with TB-like symptoms, being isolated for their own safety into separate either pop-up tents or separate spaces, stepping in and making sure if you were expecting 100 patients to come to the clinic that day, space out the scheduling, change the scheduling through text messages so you don't have the same concentration of people. Intense discipline around hand washing and social distancing and so on. Following up on patients who aren't showing up for their medicines, but contacting them, figuring out why they didn't come, fear, inability, and coming up with creative ways of getting them their meds, and sometimes in multi-month supplies. Tracking, expert patients, clients, peer clients, contacting, tracing other patients to make sure that they are coming in or other arrangements are made for them. These are individuals whose job it is to provide services at the site level. They're doing remarkable work that's not a surprise to see, but is gratifying to see, and it's reassuring to see. So let me stop there. I can't capture the full dimensions of the dynamic going on out at the subnational level and site level, but hopefully that gives you a bit of a glimpse. Thanks.
Thanks, Chip. That was, again, very complimentary to the other presentations, and thanks to all of our presenters. So what I'm going to do now is read through the chat box and pose a few questions. And if you'd like to answer the question, please feel free to jump in, and then we'll continue to ask them. So again, so the first question we have is from Ambassador Jimmy Colker, former U.S. ambassador. We all know Jimmy from his work on global AIDS and other things. He says, thank you for the webinar. His question is, with travel suspended for pretty much everyone and the logistics problems, I just want to kind of highlight the ones that Chip just mentioned. How can the U.S. effectively divert money intended for WHO to U.S.-based or affiliated NGOs, as has been proposed? Could it work? Where would it work? Where would it not work? Is there someone on the panel who'd like to take that question to start us off?
This is Jen. I'll start. I mean, this is something hi, Ambassador Colker, this is something we've looked at to try to understand and walk through what is being proposed, what's possible that the administration could do to halt funding to WHO. And just to say one thing up front, any funding that was specified by Congress for WHO, which is usually the assessed amount, is not funding that the president can just unilaterally prevent from going to WHO, but what we're really talking about is the voluntary amounts, the amounts that the agencies provide through CDC or USAID to WHO for various efforts, projects. That funding could be held back going forward, and then there is a question as to what could happen with it. And I think the risk is even there's clearly there could be other partners found for some of that work. The risk is it's a very disruptive environment right now, and as you point out, there's barriers to getting existing things moving, and so changing the flow of support does raise questions at this time as to is that adding to further disruption? Is that creating more challenges, making it more streamlined? And I really think that would have to be a very careful case by case assessment. And in the end, there's definitely risks of creating more challenges on the ground. There's probably others here who can speak to how WHO they're working with WHO on the ground in some countries, but that's my sense of it. Thanks.
Michelle, this is Chip. I would agree with what Jen was trying to say, the premise of the question, and I know why Jimmy asked it that way, completely understandable. But the premise is problematic, but that's what's in the news, and that's what we're facing. The larger question, additional resources, regardless of where they come from, there are challenges in terms of logistics and support to sites, but those services are continuing. I would still place a fundamental emphasis on protective equipment. So we don't, imagine how much worse it's going to be if frontline health workers become sick from COVID and their numbers are dramatically reduced. So resources, wherever they come from, that are for PPE, that get it in there, the logistics, the vehicles, and so on. We have essential staff who are allowed to continue with essential travel as long as they meet certain criteria. We've laid that out very, very clearly. Additional resources will help people who are able to provide services, move supplies, get treatments around. That is possible to do if they're adequately equipped and supported with the tools.
Excellent. Let's move on to the next question. I don't know who asked this one, but the question is, how has the COVID pandemic impacted the effectiveness and of other programs? Specifically, the question was around PEPFAR because of Dr. Birx's role as the head of the COVID task force. But if there are specific examples of what has happened and what the disruption is, I think people would appreciate those examples.
I mean, Chip, I don't mean to put you on the spot, but you're probably in a good place to talk about it. But I would just say, if people aren't aware, PEPFAR has been putting out regular guidance to the field about what could be done or what things to anticipate and challenges that could be very useful for people to know about. Some of the challenges that are already happening, and we heard a little bit about them earlier in the call, are noted in that guidance, such as stockouts and slowdowns in supply chains, lack of PPE equipment. So, for example, PEPFAR's guidance says that healthcare workers should have PPE, but PEPFAR is not able to provide sufficient supply, or maybe not directly at all. So I think there's questions, but that document is worth looking at to try to understand what some of the challenges are. There's a real emphasis on telemedicine and on moving any kind of outreach and prevention and other social behavioral change campaigns to a virtual format, which of course isn't going to work for some people. But those are some general observations. And the other place I would suggest looking to understand impacts specific to HIV is the Global Fund, which has mobilized up to $1 billion of its funds to provide to its countries that it supports to address HIV, TB, and malaria. And it has identified issues as well, stockouts of test kits, for example.
Jen, this is Chip. I would only add, in addition to OGAC guidance, which I think they're trying to update twice a week, USAID has likewise really moved to take that guidance and interpret it or clarify it for USAID missions, CDC likewise. There's the same adaptation that we're going through. They are also at the country level. OGAC itself has a designated leader while Ambassador Birx is at the White House, but I know Ambassador Birx is still keeping her eye on OGAC and providing help or guidance when it is required. So our focus is less on any sort of disruption because of that dynamic, and is really focused on what we're able to do within, everything we're doing so far is with existing funding. And we're needing to do a lot more in a variety of directions. And so our focus is on that adaptation at the country level. And, that's about the effect of COVID as opposed to the dynamic in DC that was referred to in the question.
I think I'll move on to the next question, if that's okay. The next question is from GBC Health. They say thank you for the informative discussions. Can we talk a little bit about the engagement of the private sector and how that could be improved? What are the bottlenecks that we're seeing and what can be done to overcome them?
I can jump in on that one. This is Purvi from Medtronic, and again, I'm just representing company foundation's view, but I'm sure there are others on the call who are seeing this elephant from a different direction, right? I think one of the things that's going on that can seem, I'd rather look at it from the place of opportunity. So let's start there, which is where I think some of my remarks are also coming from. I would say, and it dates me, but if you look at the variety of responses that have amassed over the last 15, 30 years, this one, you are seeing a full-on private sector response that's also coming into play in ways that are remarkable compared to ones in the past. And from that, I think you can see a lot of opportunity to do more. Where some of the frustration can come in is basically the same frustrations that a lot of people are having, which are around coordination. Are we optimizing resources? This is a response that we're all inside of just as much as we're all professionally providing guidance to. And that brings a very different lens to how we're moving. Everybody is inside of figuring out their own continuity while also helping others. And that heightens the need for coordination in a very, very different way. Everybody's figuring out how to get back to work. Everyone's struggling with that, and is equally empathetic to the variety of players on the ground that are doing the same. There are financial flows happening outside of the public sector ones. They're also huge, and I think the biggest question that is coming on now is, a year from now, will we know that this all mattered? And how are we able to really look at the total investment that's coming in? So there are those kinds of coordination and frustration issues, and oftentimes in places where we're not necessarily on the ground and are really relying on the strength of what WHO can offer, of what each one of these large global nonprofits can offer, and what national governments need to be ready and strengthened and in the driver's seat to move forward. So that's just one view. I'm sure there are others on that can provide other points of view.
Michelle, if I can, this is Chip.
Yes, please.
There's opportunity and need around testing. Just to take one very specific example of point of care, early infant diagnosis platforms exist across a number of countries, hundreds of sites, as I understand it, that there is a cartridge, if you will, forgive my non-technical familiarity with the details, that would allow for COVID testing. They're not inexpensive. And so trying to figure out how best to use those existing platforms that have been used remarkably successfully by ministries of health and sites around point of care early infant diagnosis for HIV. How do you take advantage of those platforms and maybe costs can be reduced in some way? I don't know what the specific deliberations are about that. But go back to my larger point before, there's a great deal of expertise and experience and knowledge about testing labs, decentralized from labs, and getting results back faster in a variety of different ways for the purposes of either case identification or initiation of treatments, whether that's for HIV or TB. So there's, in my mind, there'd be ample room and great need for stepped up use of existing testing infrastructure on the ground.
Yes, this is Gloria. I just want to chime in to contribute to some of the questions. I would just want to say that in terms of the funding restriction to the World Health Organization, World Vision has actually joined other global partners to advocate for funding support for WHO, and seeing that the people really at the forefront, our frontline community workers, need to be protected as they risk their life to save others. That is really very, very critical. There was another question on access to supplies like tuberculosis supply or other provisions. Like I mentioned earlier, because of procurement and logistics that have been affected, some of these essential services are also affected. And I think it may be difficult to really go back to business as usual before the COVID pandemic. The important thing is that partners, patients, governments, institutions will work together to see alternative ways of doing business in the new post-COVID environment, because other challenges might come and we could learn from what we're having now with COVID to be able to mitigate other impact. Thank you.
So we have one more question, and then I'm going to turn to Nidhi. And so if people can just maybe answer, we have one person answer this question, and then we'll close with our hearing from the task force. The last question comes from UT Austin. The question is around what strategies are implementing organizations and funding organizations using to coordinate their efforts in this emergency situation, and are there specific challenges that are specific to the pandemic that were not true in the past? So maybe if one person could take that question, then we'll go to our closing.
If you want me to, Michelle, it's Chip. I'm happy to. There are unique challenges. Absolutely. I think the fundamental coordination needs to be at the country level between the different Ministry of Health, Global Fund, PEPFAR, and other partners. What's fundamentally different is the requirement of, because of the contagion or the potential of contagion. So I come back to personal protective equipment. In the absence of that, and there are places where it is absent, you really can't do the kinds of things, even if they're in principle well coordinated in a national capital or outside of the country. So who's responsible for bringing in that PPE? Some of it's donated by countries and by through philanthropy. But that central, all the good that can happen, even in these circumstances, starts with safe and healthy frontline healthcare workers and those who are working hand in glove. Maybe that's a bad metaphor right now, but nonetheless, working with them. And so there are a range of new and different and difficult challenges that have cropped up. And challenges, it's related to that when the objective is continue the highest level of services possible. But in order to do that, a number of other things have to happen. And there's an additional element of urgency that creates additional coordination challenges. So they are rife in individual countries. It's not the same picture in each country, quite the opposite. But the fundamental place for that to happen is at the country level, at least in terms of delivery of services on the ground. Let me stop there. There's so much more I could say about that, but let me stop. I know you're trying to keep to time.
Thank you, Chip, and thanks for being sensitive to time. And so I just wanted to turn to our final presenter, Nidhi Gori from the USAID COVID-19 Task Force, just to give us a brief update and share some current thinking.
Great. Well, thanks so much. And just thanks to the Kaiser Family Foundation, Global Health Council, and all of the panelists today for the time and the thinking in this discussion. It's been really valuable. And I also just want to especially thank the Kaiser Family Foundation for their really early and robust efforts on donor coordination. Coming from the donor side, I can say it was very helpful to us as well. I just want to talk briefly about USAID's approach for this response in terms of what we're doing and how we're coordinating, and then share a bit about our thinking on COVID's impacts and LMICs particularly. I think, as many of you know, for more than half a century, the United States has been the largest contributor to global health security and humanitarian assistance in developing countries. We built the foundation upon which the global health system is based, and we have had staff and American organizations on the front lines in a range of crises, both humanitarian and global health, large epidemics such as HIV/AIDS, consistent work on tuberculosis and malaria, and of course now with the novel coronavirus with COVID, despite our efforts to also continue to battle COVID on the home front. Since the outbreak of COVID-19, the U.S. government has announced, as noted earlier in this presentation, more than $775 million in assistance specifically aimed at fighting the pandemic. And that looks at preparedness, prevention, and response to COVID. So looking at all kind of spectrum of how to handle the outbreak. The funding will save lives by improving public health education, protecting healthcare workers, expanding access to safe water, sanitation and hygiene, strengthening labs, increasing disease surveillance, and rapid response capacity in more than 100 countries around the world. We are building upon and leveraging the resources we have for the robust global health programs that USAID and other parts of the U.S. government have built upon over the years. So we're looking at leveraging programs such as PEPFAR and PMI, other efforts that aim at focus on maternal child health and tuberculosis and immunizations, not just so that we can ensure continuity of other essential services throughout this pandemic, but so that we can utilize those networks to also expand the ways in which we engage to support countries in their fights against COVID. In terms of how we are working with others, our team here on the USAID COVID Task Force is working very closely with the State Department, the CDC, HHS, and Department of Defense, as well as several others, on an all-America response to support health systems, humanitarian assistance, and economic security and stabilization efforts worldwide, with about $2.4 billion in emergency supplemental funding that was allocated by our Congress. We're also coordinating very closely with external partners, including international organizations, the donor community foundations, and the private sector, as well as others, to ensure effective and streamlined support to the global effort to combat COVID, and to also continuously be looking at what are new and innovative practices that we can support, that especially those that might have max impact in developing countries. We're working, of course, with global consortiums of the NGOs, many of which you all are part of, and other organizations such as Interaction or the Global Health Council on information sharing, and most importantly, to hear from partners directly who are delivering life-saving interventions about what's working and what's not, and their thinking as to what might be coming down in terms of impacts of the disease. In terms of our thinking about how we're looking at COVID and LMICs, as many of you know, some of these countries are still in early stages of the pandemic, but there are also several where the impact is already being felt. And while we know that there are countries in early stages, we can foresee the ways in which their communities and societies are likely to be impacted. We've already seen health systems strained in several countries, including Ethiopia, Nigeria, and South Africa, just to name a couple. We've seen that more medical staff are needed in a range of countries, ranging from Haiti to Mongolia. We've seen that millions of children can't go to school, and that itself presents challenges to communities. And we've also seen that the risk posed by coronavirus, is especially high for millions of people who are living in poverty and extreme poverty or have recently emerged from it. There have also been several reports that about COVID's relation to economic hardship and confinement pressures that are contributing to an increase of gender-based violence and other protection concerns. While legal protection measures exist in some LMICs, most lack adequate resources and influence to provide the assistance that people may need in this space. We also anticipate impacts across a range of sectors, including governance, economy, rule of law, logistics and supply chain, education, energy, tourism, health, agriculture, and food security, which is a long list, but also not fully comprehensive. And just that underscores that the virus will not just cause serious disruptions and needs in terms of the health sector, but will have significant rippling effects onto economies and financial systems, both with short-term and long-term repercussions. And these disruptions might particularly harm already vulnerable communities. And so our interest is really to understand those analyses so that we can support programming that's not limited to health, but looking at the entire impact that COVID will have on different communities. We're therefore developing plans to match field-level data and assessments of needs with our technical expertise in global health, humanitarian assistance, and second-order impacts such as economic recovery, so that we can deploy as USAID our resources more quickly for where they'll have the greatest impact. We continue to work on building and strengthening the resilience of other health programs and systems to ensure continuity of services throughout the outbreak. And this will enable us to strengthen key components critical to the COVID response and to recovery, such as supply chain, availability of healthcare workers, and health information systems. Our goal for USAID is to ensure that our critical life-saving work and mission will continue in spite of COVID, and we've therefore already reoriented our resources to ensure this remains our highest programmatic priority. We're looking to not just support our existing programs in a range of areas, but then also how to amplify and expand COVID programs to address the COVID's impacts and its potential impacts in several countries. We're adapting the way that we do business amid this outbreak, just like several other organizations are, to ensure that we've got the right people focusing on the right things to drive different aspects of this response. And just in closing, I think there were several comments that I would echo throughout what different presenters and in questions came up today. But I think it goes without saying, and we all know, this is an unprecedented global pandemic, which will have profound impacts on LMICs, and the impacts could vary quite greatly on each country, depending on the different vulnerabilities that they might have. We're very much committed to working together to support these nations with their preparation, response, and recovery from COVID. And we look forward to the continued partnership with many of you as we work together to leverage all resources possible to address the pandemic. So thanks very much for the time today and for inviting me to join this call.
Thank you so much for that good summary. And I want to thank everybody. I want to thank Kaiser Family Foundation. I want to thank Global Health Council. I want to thank Parvi and Chip and our World Vision representative and everybody who spoke on today's call. It was really informative and helpful, and look forward to follow-on conversations in the coming weeks. Have a great afternoon and stay safe, everyone. Bye-bye.